Actually, I just noticed there is a set of lights here, which I didn't see when I was talking. And I guess it goes yellow, and then it goes red, which means you're over time. So I have the distinct pleasure of introducing a very, very distinguished member of our field, Velma McBride Murry. Dr. McBride Murry is the Lois Autry Betts Chair in Education and Human Development and the Joe Wyatt Distinguished University Professor and a Professor of Human and Organizational Development at Vanderbilt University. Dr. McBride has conducted research on African American parents and youth for over 15 years, and she developed and tested the Strong African American Families Program, a blueprint designated program. Very, very well recognized in the field and very important. She's the author of over 100 scientific articles and has served on the National Academy of Medicine Consensus Study Committee on improving the health, safety, and well-being of young adults. She is a member of the National Academy of Medicine's Board of Youth and Families, and a number of other important organizations and groups. And most recently, she has received two very important awards. One is the Award for Contributions in Community Culture and Prevention Sciences from the Society, really the International Society for Prevention Research. And she's also received from the American Psychological Association the Presidential Citation for Distinguished Research and Contributions for Children, Youth, and HIV/AIDS. Please join me in welcoming Dr. Velma McBride Murry.
Thank you, Jose, and also Leslie. I'm delighted to be here today, and it's a topic that's very important to me as a person that's done research with communities that oftentimes don't have access to psychoeducational programs, and so they've taught me a lot. And as I mentioned to one of my colleagues, Gladys, as we were talking today, and it is that I had a lot of questions as I began to think about what I was going to talk about today. And Anthony, I'm assuming this is my clicker. Okay. Okay. And it also tells you how much time you have, Jose. Yes. Is that it? You're doing it. Okay. So as a person that teaches college students, we always start with telling them what we are going to tell them and then tell them and then remind them what we've told them. So what I'm going to talk about today are some challenges but also opportunities in the area of trying to move these programs from the shelf to the communities in a way that's respectful of them. And then as I'm going to share with you the questions that I kept thinking about as I began to think of what is it that I'm going to share with you, because there's so much to talk about, so how do I narrow it down? And what I ended up doing was asking myself a lot of questions, and so I'm going to share with you those questions that I've pondered. I'm going to also talk about ways in which there is consensus about what we need to do, and then those areas that create tension. And it's really the elephant in the room that we oftentimes don't want to admit that the elephant is there. We have some theoretical frameworks that we've been informed that's supposed to help us understand how to do this work, and I will share those with you briefly, but to give us a way of framing our thoughts about the mechanism by which we can move these programs from the shelf to the community. Then those things that appear to in the research literature that say are very influential in determining whether or not communities will uptake a program or not. And I think it's important that we know that. Then, how do we deal with this adaptability and fidelity issues? Because we all know that it is going to change, and the program developers need to realize that it's going to change. But how do we work toward balancing that by partnering with communities? And then I'll share with you 3 case studies where I think we can learn a lot from them, and not that I'm a legend in my own mind, but I'll also share with you what we've done in our efforts to work with rural communities, and then I have some concluding thoughts and recommendations. So, these are the questions that came to me as I was preparing for this talk. How do we systematically integrate evidence-based interventions within service delivery systems and settings? How do we fully engage communities and consumers for whom the interventions have been targeted? What factors and processes influence implementation quality? And how do we balance fidelity, as I mentioned earlier, when we're moving these into a complex community settings that oftentimes don't have the same kind of resources that we have in our academic institutions? So how do we do this? Is it important for us to culturally tailor programs? There's an assumption that somehow if you look a certain way, we gotta do something to make it appear that it's designed for you. So if we do it, when, how do we do it, for whom, and how much, and how do we evaluate whether or not this cultural layering of the program is making a difference? Do we have on hand now evidence-based programs that are ready to be scaled up? And do they scientifically meet the needs of major populations such that they can be widely disseminated? And the community, so it's not just culturally tailoring for racial ethnic groups, but culturally tailoring for communities. And that's an area that we spend very little time focusing on in our area of research. And then, are there guidelines for practices to inform us about how we're supposed to do this? Because surely we're not starting from base one. So what do we already have that we can begin to pull together in order to begin to understand how to do what it is that we say we're getting ready to do? Next, Anthony, thank you. So some things that we have consensus on is that we know community engagement is important and that it's a critical process to guide how we're going to implement these programs from the shelf to the communities. We also know that it's important to establish partnerships between the community members and the researchers, and to make sure that we understand that all those that need to be at the table are at the table and involved. All of these things we know. We know that it's important to have feedback, not only from the researchers to the community, but from the community partners to the researcher, that's important. We also know that we can't only collect data about how things are working with numbers. And so we believe, and there is consensus, that mixed methods approaches toward understanding this implementation process is important. And we also know that adaptations will occur in real world settings. But it's almost like we put blinders on the fact that this is gonna happen. And so now that we know that it is, and as we're moving them out from these ivory towers to the communities, let's talk about how do we put structures together to ensure that everybody is happy. Next. So it's the elephant in the room, and this says, honestly, I preferred when we didn't talk about the elephant. And so the elephant is there, but we prefer not to talk about it. And in order to move forward today and tomorrow and to guide the field, we've got to address this elephant. And we've got to be honest and open with each other, community stakeholders, researchers and program developers about how to do this, because we're facing some really critical, serious situations in our country that we have been testing programs to say we know how to really avert those problems, but we're not doing any good if we finish these multi-million-dollar programs, as many of our funders will say to us as they're looking at us that have those funds, if they are still in our labs in the university settings, and we're just looking at them and publishing from them. Okay. So it creates tension then, and it's because we oftentimes have different agenda. So for the community partner, the agenda might be, I want to do this to improve services for the constituents for whom I'm representing, or for the individuals for whom I'm providing services for. I want to increase program capacity and to build my staff skills so that we can do a better job of doing the work on the ground to meet the needs of the families. I need more funding in order to be able to sustain these programs that we have. And I need for you to help me understand how to document impact, because that's needed in order for me to get funding, but it also may be needed in order to change individuals' views about policies associated with hindering the kind of work that we want to do. So then the researcher and the program developer, for most of us, and that's why we hold really hard to making sure that nothing muddies the data, we want to make sure that we find these effect sizes that's strong enough so that we can get them published in these highly visible journals. And that then is of interest only to the choir. We want to expand opportunities for our graduate students, our postdocs, our undergraduates, to get some lived experiences in the field, or our project staff to learn how to do this work in the field, in order to then position us to get additional grants and to raise visibility of our institutions, because that's how we get our merit pays and all the awards that really don't matter at the end of the day, when you're looking at what's really happening in the life of people living their everyday life experiences, sometimes in very stressful situations. Yeah. So there are theoretical frameworks that, for those that teach prevention science research, tells us how to do this. But I'm not sure how much we are listening to this. And even as I was preparing this presentation, I said, I know that. I teach a prevention science course every fall. We talk about this. We look at logic models to help us understand how to do this. But it remains an issue. And the question for me is, why does it continue to remain an issue of doing this effectively when we're supposed to have theories to inform us how to do this? So let's talk about the diffusion of innovation theory. So the diffusion of innovation theory says, in order to be able to understand how to move programs throughout widespread dissemination, individuals have to first know about it. So how are we informing people about it, about those programs that are evidence-based in the communities? What is our mechanism for disseminating this information to increase awareness? Once you know that, then it helps people make decisions about whether or not they're going to do it. So they look at it, and am I persuaded by what the program says it's supposed to do to uptake the program? Yes, then I decide to do it. If I decide to do it, then I need to then begin to do the implementation of it. Then the question becomes, in the process of implementation, do I get what I think that I'm supposed to get from this program based on what the program says it's supposed to do? If the answer is yes, then you're probably going to keep it. It's affirming. It confirms what it is that you thought you were going to get from this. If it does not, then you're less likely to sustain it. But the first part of this diffusion mechanism is to develop social network processes by which information about the program is spread. And for many of us, we think that we're spreading it by our research publications. How many people in the community are reading our articles? None. And how many policymakers are reading our article? Very few. So how do we get the word out? And I think that's one of the basic steps of this whole process is understanding if we have these programs, how do we let people know other than looking on the website to see which ones are blueprinted and which ones have been endorsed by CDC? It's another mechanism by which community people aren't going to do those things because you have to be in the academy to know these things. So, Anthony, I keep thinking that I have this. So, what influences then the extent to which once a person knows about the project, the extent to which they're going to uptake it? One is, what's the relative advantage of taking on this program when I may have something I'm already using? It's from my kitchen that I've developed myself. You ask me, do I have efficacy data? I say no. And I'll do a sidebar story because I'm a storyteller when I talk. So I was at a meeting last spring at APA, American Psychological Association. And they brought a group of us together, and Colleen, I think I'm remembering this situation now. They brought a group of us together to talk about social justice and equity, and then it spilled over to the Board of Children, Youth, and Families, developing a series that's coming out very soon that you should probably hear about. But I was at lunch talking to this young man who informed me that for 25 years, so maybe he's not that young, but he's young to me. For 25 years, he and a group of men from his church have been fathering young men in the community. And he said to me, we get them when they're very, very young. They come to church on Saturday mornings. They're with us all day. We eat, we talk, we play games. But the focus really is on encouraging these guys in St. Louis, is where he is, to go to college and to be future-oriented in their thinking. And he said, and we have 100% of these guys over the course of 20 years have gone to college and they finished college. And I said, how are you doing this? He said, we're just carrying community people. I mean, there's nothing magic about what we're doing. We're just carrying community people. And so then Cheryl Boyce, whom most of us know, she has a way of connecting people in blind dates. And so she comes up. I really met this guy through her. She said, you need to work with this guy to provide some evidence for his program, document what he's doing because what he's doing is working. So we're not even thinking about what is currently being done in these communities when we're going in saying to them, take mine, it works. The other thing that is important is the compatibility of the program to the existing values and practices of the community. How is your program meshing with the values and the norms of this community? And just because it works in clinical trials, what are the values that are latent, which we may not, oftentimes we think we're doing this value free, but the fact that you have a theory of change suggests that it is not value free. And then it just should not be complex. There should be an ease in being able to deliver whatever it is that you want communities to deliver, and it needs to be simplistic. It shouldn't require getting a PhD in order to run these programs. There has to be some way of observing the results. So observable results are very important. They reinforce the fact that what you're doing is working, and then they have to see some results from you as well of that the program is working. And then they may want to know whether or not they can take it on and try it out before they say, yes, I will do it. Does your program allow for that? Does it have the flexibility to allow the user to begin to experiment on the innovation? Next. So the organizational change theory suggests So that was the diffusion of innovations. And one of the key things to remember in the diffusion of innovation is that it assumes that a program is not complete when the community gets it, and that there should be some flexibility in the reinventing of the innovation. So it means then that it's assumed that adaptation is going to occur because the program can't live on the laurels of its own experiences. So the organizational change theory suggests that in order for communities to begin to uptake a program, they go through stages of thinking about doing this. And that those stages, oftentimes there are 5 of them, where there's a pre-contemplated process. Do I really want to do this? All the way to actually adopting it. But in the process of trying to make the decision about the stages of change, these are things that communities oftentimes think about. What is the need or the problem that our community is facing? And is your program doing that? What are the solutions that we need to begin to think about in the process of making decisions to change? What then is going to be our course of action? And then how do we then begin to implement this course of action? And then once we see that the course of action is working, do we see now that we can actually institutionalize it so that it becomes a routine way in which we do what we do in our community? And that this process takes time. And so when we go into a community and we give these presentations to faith-based organizations or to school systems or to service delivery agencies, and we come back with people saying, I'm not quite sure, I need to know a little bit more about your program. Researchers and program developers are oftentimes offended because we say, we have these efficacy data. Don't you see how well this is working? But it's a relationship. I gave a talk the other day at Murry Medical College to a group of students about building and sustaining community partnerships. And one of the big issues that we talked about was the fact that you have to realize that people it's a relationship. And so when you're first meeting someone, as Jose talked about Leslie earlier, it's really a blind date. You're just really getting to know each other. And so oftentimes, people aren't willing to invest in the time it takes to develop that relationship in order to be able to then begin to build what it is that we want. They're not going to take this from strangers and then implement it in their community for individuals for whom they feel very close to, or they teach in Sunday school every Sunday. I'm not going to take something just because you say it's good, in other words. So the change is going to be due to the extent to which it's really meeting the needs of the community. Next. So there are a lot of other theories, and so the stage theory goes from pre-contemplation to balancing decision. And then there is this health belief model, which are often individual level models, but we can think about them at a community level as well, whether or not the community feels that whatever it is that you're talking about, they're actually something that's going to happen in their community and that they're susceptible to it. And then what are those cues to action that will cause people to begin to want to actually adopt your program? And then you have to begin to think about this process in a social cognitive context. And then for the community model in particular, it's looking at social network as a way of thinking about moving these projects into the community, making sure that you understand who the opinion leaders are, all the way down to beginning this network weaving in order to be able to expand the capacities of these communities in order to be able to uptake the program that's evidence-based. Oh, I got lots of time. So let's talk about balancing fidelity and adaptations to fit the community context. That's a really hot topic. That is a big elephant. And oftentimes we're only looking at the left side of the leg. So it's a big elephant. So let's just talk about this. Next. The reluctance And I'd like for, hopefully the groups will really spend some time focusing on this. That's an area of tension that oftentimes creates a major barrier of people being willing to uptake a program, or the program developer giving the clearance for it to move into the community. The reluctance is often based on the assumption that those core elements and those core processes must be maintained and delivered exactly the way that it was attested in order for the same outcomes to emerge. Oh, did I move that? You moved that. I'm not ready. I know Anthony well, that's why I can say that to him. So it assumes then that whatever this theory of change is universal. And if you believe it's universal, it means that regardless of the group, regardless of the context, you're going to get the same if you follow this recipe exactly the way it is. Now, I'm a baker, and I know that ovens change the extent to which your bread will come out well. Patrick Tolan is a baker. He understands that. And so it's the same recipe. It should have the same results. But you've changed context. I have a new oven. Somehow it shifts. So why can't we think about these programs the same way? It may be the same theory of change, but the processes by which we get there may be different. And more importantly, what I'm beginning to realize in my own work is that even the things that you target in your preventive interventions, if it's universal, it's touching a lot more things that you didn't even think of because it's universal. And if it's universal, it's not only affecting one domain of people's behavior or people's development. So we assume, we're reluctant to do this, and I'm talking to the choir, and I'm part of the singing group. And that is that it's universal, you do it the same way, you get the same results, you have to do it that way. We gotta talk about that because communities aren't such that they can do things just the way that you do. I had a church once, faith-based organization once, that said to me, do I have to do all of the 7 sessions? Or can I choose the ones that appear to be more relevant or that we like more? You know, and as developers, we just go like, what? No. But how do we know that? How do we know that unless we begin to systematically examine that? Okay, now, Anthony. So then how do we balance this? Identify core components of the program that provide guidance on how, what, and when to change and adapt. And that is a collaboration, not just the researcher and the developer, but a collaboration. And then it's important to validate what it is that your program has really shown to be effective by sharing the data, letting them know that this is how it happens. And once they understand that, then they may tweak it to say that, oh, that's how you got there. Well, then maybe we can use this particular process to get there. They need to also know what all of the components of your programs are that may be contributing to the change. What we oftentimes do is just share the curriculum. But there are other things going on in the backstory, the background. It could be the way that you trained your program implementers. It could be the fact that you have homework assignments and the processes by which you go through that with them during the session. So that's important. And then include implementation assessments to be able to capture the adaptation process. We can learn a lot from the implementation of our programs in real-world settings by looking at what people do to it once they have it. And then if we see that the intervention targeted changes are better, that's good. According to the diffusion of innovation theory, that's a good thing, because it means then I can then make those adaptations and refinements for the program. But we as program developers, and I'm talking to myself, so this really is a talk for me too, we need to be flexible in our process of moving these projects into the field. Okay. So the other big issue is cultural adaptation. And this clock is right? Okay, cultural adaptations. So many of us have heard about this, culturally tailoring. And so I'm gonna talk about the two schools of thoughts about this issue. Okay. The first one is our thinking that delivering a standard program would result in high probability of failure. When we have these evidence, empirical evidence to say there's something about your program, if you deliver it the standard way, it may end up being very low change for certain populations because of how the program is designed. But in our world of testing efficacy trials, we first test the original program on a group, see if it creates change, then we say it requires culturally tailoring as a consequence of that. But what if we start from the community up? A novel approach, where we say to the community, how important is it that we infuse and integrate culturally relevant issues in the context of delivering this program, and have them help us decide whether or not it's important? Because it may not be, but we think we know that because of what we find from our evidence-based trials. And then when culturally tailoring occurs, how much adaptation should be made and infused in a program? Should it be changes in the content and the process as well? Should it be just surface changing, or should it be deep structure changing, as my colleague Castro and his colleagues focus on? So let's talk about the surface versus the deep structure adaptation. So in the surface adaptation, which is what a lot of programs look like, they are original programs with faces of people that look like the target population that's receiving the program. Or it's been translated into Spanish or Japanese or whatever. So it's really superficial to say that it's culturally tailored, but that is the intent. And maybe that's all it needs. Maybe it holds well enough such that if you just change these graphics, these examples, if you match the program implementers to the target population, maybe that's all you need. Then there are other processes, as Benil Guillermo and his colleagues would suggest, that require much more deep structured changes, such that the problem of interest is very culturally based. And so therefore, it's important to move people to a particular place as a consequence of integrating important parts of their culture in the process. And so let's just look at a few examples of culture when you're looking at deep structured changes. So it's not just the language, but you're also integrating the meanings that people may have about the issue, the values and the rituals associated with processing these rituals in their own communities, customs, religious practices, experiences. How can we begin to really think about this? 1 minute? What? I'm looking at this. I have 13. Okay. But I can stop whenever you want me to stop. 5 minutes? And their worldviews. I'm just moseying along because I think I have forever. Okay, let's go. Let's go, Anthony. Let's go, Anthony. So I'm going to talk about, really, I'll talk about what I can, then you're going to stop me. Okay, so what I then began to think about is, for those programs that have scaled up, what have they done to be so successful? And David Oles, we all know about the Nurse Family Partnership Program. So this is what he said he did. He partnered with the community in the development of the program. He had ongoing support for program implementers. So once the program was embedded there, with the partners having created the program, he continued to provide support. He clearly articulated to the communities what the program purpose was and how the program was designed in order to accomplish the core elements. Having that information then will allow the community to know what they can change. He then began to, through the community, monitor and assess the implementation process, and information about the process was used to improve the program. Diffusion of innovation. And then he has shown that this works across diverse populations. The next one is investing in kids. And I loved this particular project because they talk about the role of a broker. And I think that's going to be key in our being able to bridge these two worlds that have been far apart. How do we get someone to serve in this broker role? So Inc., or Investment in Kids, they use broadband community support and involvement in order for the community to identify goals that they have. It's like a needs assessment. Once they do that, then they develop strategies for the community to ready itself for the program that they will then begin to implement. And then they are there, similar to Oles, helping with the implementation of the project. And in the interest of time, let's just flip a while. I thought I had one. Okay, let's keep going. So you won't hear about mine, but these slides will be available, and you can ask me at lunch. And so I want to get all the way down to the recommendations, so it's a few slides away. You can see how much time I thought I had. Let's go back to this model. That's where maybe I'll end it. So this is a model that has guided the work that we've done in rural African American communities for many, many years. And so key to this process is the community partnership. And that's the first block that's guiding this entire model, where our community partners work with us in the process of developing an understanding of the theory of change, and more importantly, helping us develop what we call prescriptive theories about how the process or the program should be implemented in their community. They're there at the table with us, helping us understand that. That then informs our preventive intervention, and then it helps us understand about dissemination, but it also helps us understand more about adaptation and fit to fidelity to meet the community needs. Now I'll end with the recommendations. More. Yes, okay. So the recommendations are: establish guidelines for best practices for scaling up. This partnership is here. Make sure that the community know what the core elements of the program is and allow for refinement. Those programmatic changes in real world settings can work better if communities are allowed to translate and tweak, refine, modify. We need to also establish criteria and processes to allow communities to be ready themselves. Give them time to ready themselves for the implementation of the program. And that could include lots of things in the process, but they can tell you what it is that they need. And we should also begin to consider alternative delivery modalities of our programs, because the traditional methods of delivering programs, while they may have been good in the past, families are living in the 21st century and communities, and we need to come up to that, and I will stop. Thank you. Okay. I have 5 minutes. Oh, this is our presentation. Yeah. That's right.
Can't hear. A major point I gather was that, and first of all, great, calling us to say we need to face this, we need to do this. This is what we need to do, as opposed to who cares what everybody else needs to do right now. I think that's great, but one of the things you talked about, and I want to see if I understood it, is that people are trying to argue that these things fit everybody, and so they have to be done as they're done because it works for everybody the same way. I don't think many people are really claiming that. I think what they're claiming is it works, what has been proven to work is what's been proven to work, not the adaptations, not the variations, not the, so that's why the fidelity is so important in prescription.
Yeah.
So, and I think that kind of flips it changes the conversation a little bit about adaptation.
Yeah, and so you're right. So what we claim in our efficacy and effectiveness trials is that these are the mechanisms by which change occurs. It's been tested, we show that it works, but we've done it in these clinical settings. So the question for me is, what happens when the Department of Family and Children Services take your SAFE project and they deliver it and they use the same recipe that you've used or that I've used, and then they find that I gotta change some things here because it's not working. We can't do it this way. We can't do it this way. And so if they can't do it that way, do we say to them, I'm taking my program back? Or do we say, do it and let me see what happens as a consequence of what you've done? And be comfortable enough to let them do it. And then, as David Oles has found, then incorporate that. And then somebody will fund us to then do an implementation effectiveness trial based on what they told us is working. Then you begin to have an evolving project that started out originally looking like this, and it may have some of the similar, it may look a lot like the original program, but it's cousins, it's a cousin of that. Then we agree.
So I wonder if there's an intermediate point, and I think you did talk about it, which is, what are the essential elements? Mm-hmm. And you're suggesting we don't change the essential elements,
Yeah.
but there is a fair amount that's not essential,
Yeah.
and maybe that could be changed.
Exactly. And so what I really think about in the process of adaptation is it's the process by which the core elements are shared in these group settings. And so if future orientation is important, but my curriculum has a certain way that it has to be discussed with visual images and discussion of the group, but then I take it to a church and the church may say, oh, future orientation. Well, we're going to talk about it by having a sermonette. And we don't like your graphics, nor your examples. But we're still talking about future orientation. Or we're still talking about regulated communicative parenting. But the process by which we get there may differ. And so, can we allow that amount of flexibility in our programs? And a strong program should be able to withstand the pulling. and we learn from it. Dr. Hawkins.
I think that this issue is really a key issue, and the question is about planned implementation and adaptation versus situational adaptation.
Exactly.
And when Del Elliott and his colleagues were trying to do replication of a number of programs, what they found that often it wasn't the planned adaptations that were a problem, but it was situational adaptation. I'm a teacher, I'm doing this curriculum, and I don't really want these kids to be practicing these exchanges because that's going to get out of hand and chaotic. And so I think what you're emphasizing that's really important is as communities are looking at these things and looking in advance at them, to say, what can we do that works for this community, given our culture, given our heritage, given who we are, that will bring this program to life in our community. But I think we have to distinguish between planned implementations in advance as people look at something and say, can this work here, versus kind of situational adaptations when people say, oh, I don't have time for that, or we got too much time on this and so we aren't going to do that. And the result is you don't get the core elements transferred.
In
and
those situations.
And that's a big issue that I don't think we necessarily solve with planned implementations, and that we do have to deal with, because those adaptations sometimes can mean that you don't get the core elements provided.
Exactly. And the planning, great comment, Dr. Hawkins, I appreciate that. The planning needs to occur with the community involved in the process of the planning. And it can't be top down, where we tell what needs to happen as academicians. It has to be both and. We're sharing this. Yeah. Finished? She just stood.
Okay.
It's his fault.
Oh, we finished?
Last question.
Oh, okay. I just wanted, this is such a core issue related to research practice and practice, having been a researcher and a public health practitioner. The problem is, we need a new paradigm here. We could look at continuous quality improvement as a paradigm where you track things as you go along with a goal there. Maybe you drop one whole element in your adaptation because your goal is to get to self-sufficiency. But if we do that, and I could tell you, even implementing goals, you have to make changes in the community, very different than what he wants, but then it's very hard to publish because you don't have a random kind of assessment, but you have proof over time with what you've done, monitoring with quality improvement, you've gotten to the best infant mortality rate. So there's a dilemma on all of these sides and what you've raised.
It is a dilemma, and as Jose said earlier, we got these enormous brain power, and we're going to come up with a solution over the next couple of days, because the field is in need of what it is that we're talking about, and we best get doing. And I'm going to quit.